The objectives of my lecture, the advantages of the beach chair position, disadvantages, incidence of neurological complications, physiological effects of the sitting position, the effect of anesthesia on the physiological responses, and how to minimize the neurological complications. 20% of the elective procedures in USA are shoulder surgeries, and 80% of these procedures are done in the sitting position. So it seems that sitting position provides many advantages, like ease of setup and conversion to open technique, better surgical exposure, and less traction on the brachial plexus. The disadvantages of the sitting position are an increase in stroke volume, cardiac output, mean arterial pressure, and cerebral perfusion pressure, and so there is an increased incidence of neurological complications like stroke, coma, spinal cord injury, and blindness. So, the incidence of neurological complications in the sitting position, they are rare, but they have fatal and disabling consequences. The incidence of neurological The incidence of neurological insult is about 0.70% within 30 days post-operative. And as I said, maybe it's rare complication, but it may be disabling and fatal complications. What are the physiological effects of the sitting position? What happens when you get from a supine position to a sitting position? What happens that this increase in venous return due to cooling of the blood in the lower half of the body? This decreases the left ventricular preload. So this decreases the stroke volume, decreases the cardiac output, and decreases the mean arterial pressure. So what happens to compensate for this? This is detected by the baroreceptors that are located in the carotid sinus and the aortic arch. They are supplied by the vagus nerve and the glossopharyngeal nerve, inhibiting the vasomotor center usually when it's cellulated. The decrease in mean arterial pressure decreases the baroreceptor stimulation and releases the vasomotor center from inhibition, giving the way for the sympathetic outflow for positive inotropy, chronotropy, dromotropy, and the vasoconstriction to return the arterial pressure back to normal. What is the response of the cerebral circulation? Do we faint when we get from a supine to the sitting position? Usually there is what's called the cerebral autoregulation. The cerebral blood flow is about 50 milliliters per 100 gram of brain tissue per minute. The cerebral autoregulation means that within a range of about 50 to 150, there is a physiological response that maintains the cerebral blood flow constant at 50 milliliters per 100 gram of brain tissue per minute. As we know that the cerebral blood flow equals cerebral perfusion pressure divided by cerebral vascular resistance. Sorry for this error. Okay, this error here, cerebral vascular resistance. The change in the cerebral perfusion pressure in one direction is associated with changes in the cerebral vascular resistance in the same direction, in the same amount, to keep the cerebral blood flow constant at the same rate. So what's the effect of anesthesia? What happens when you change the position of a patient from the supine to the sitting position under anesthesia? We know that the mean arterial pressure equals stroke volume multiplied by heart rate multiplied by systemic vascular resistance. What happens? What is the effect of anesthesia on stroke volume and heart rate? The anesthetics are mostly cardiac depressants, so they increase the cardiac output. Secondly, due to pooling of the blood in the lower extremities, this decreases the left ventricular preload and increases the cardiac output. The effect of positive pressure ventilation, this is a considerable effect. The positive pressure ventilation decreases the venous return and decreases the preload, left ventricular preload, and increases the stroke rate. And to this effect, there is blunted baroreceptor response. What compensates the decrease in mean arterial pressure when you get from supine to the second position is the baroreceptor response. So, added to the effect that they decrease the cardiac output, they blunt the compensatory mechanism, which is the baroreceptor response. Regarding the systemic vascular resistance, most of the antibiotics decrease the systemic vascular resistance, and the decrease in systemic vascular resistance on the venous side, the venous dilatation causes decrease in the preload, left ventricular preload, which also decreases the cardiac output. So the end result of this effect is a decrease in mean arterial pressure. So let's look at the central nervous system. The neural integrity usually due to the balance between oxygen supply and oxygen demand. The oxygen demand is, we can get from the equation, DO2, which is the oxygen level, equals cerebral blood flow multiplied by the arterial oxygen content. The cerebral blood flow equals, as we said, cerebral perfusion pressure divided by cerebral vascular resistance. Cerebral blood flow is constant within the auto-regulation range, which is about from 50 to 150 millimeters. So what's the effect of these changes that happen intraoperatively? Hypotension will decrease the cerebral perfusion pressure and will decrease the cerebral blood flow. Okay? The volatile anesthetics decreases the cerebral perfusion pressure, but it decreases as well the cerebral vascular resistance. So it may keep the cerebral blood flow in a reasonable range. That effect may be beneficial over the IV anesthetics. As Bill said, the IV anesthetics decreases the cerebral perfusion pressure, but in contrast, decreases the cerebral vascular resistance. So the end result is a decrease in cerebral blood flow. A lot of studies are done to compare the effect of volatiles and IV anesthetics on cerebral oxygenation, and they found cerebral desaturation that's more profound with IV anesthetics that gives some upper hand for the IV anesthetics. CO2 levels, we know that between a range from 20 to 80 millimeters of mercury, there is a linear relationship between the CO2 level and the cerebral blood flow. The recommended range for CO2 level is between 40 to 42 millimeters of mercury, but above this level, above 50, this may abolish the auto-regulation. Vasoconstrictors increases cerebral perfusion pressure by increasing systemic vascular resistance, but may have effect on cerebral vascular resistance that may be more than the increase in cerebral perfusion pressure, and the end result may be an increase in cerebral blood flow. Studies when comparing the vasoconstrictors and inotropes like beta-cells, like ephedrine, for example, ephedrine increases cerebral perfusion pressure and increased cerebral vascular resistance, but the increase in cerebral perfusion pressure was more than increase in resistance, and the end result was an increase in cerebral blood flow. The study comparing the vasoconstrictors like phenylephrine and ephedrine showed that there is cerebral desaturation more with the vasoconstrictors than inotropes. What are the risk factors for neurological complications? First, there are patient factors. First, old age, especially if they have risks for cerebrovascular disease like hypertension, diabetes, carotid artery stenosis, vertebral basilar insufficiency, previous history of stroke, and so on. Secondly, an incomplete circle of Wallace. Circle of Wallace is some sort of collateral circulation in the brain. The circle of Wallace is formed anteriorly by the two internal carotid arteries that divides inside the brain to the middle cerebral artery and the anterior cerebral arteries. The anterior cerebral arteries are communicating anteriorly by one acon. Posteriorly, there is a basilar artery that divides two posterior cerebral arteries that they communicate artery, forming a complete circle that provides a blood circulation if there is any ischemia or any obstruction in the circulation. A study showing that about 59 to 79% of adults may have an incomplete circle of Wallace, and this may be a risk factor for ischemic injury during septic position. Operative factors: first, low mean arterial pressure. This is very important point. Low mean arterial pressure below the baseline values. Prolonged hypertension. Massive blood loss, we said that DO2 equals the cerebral blood flow multiplied by the arterial oxygen content, and arterial oxygen content is mainly defined by the molecular level, so massive blood loss can decrease the oxygen delivery. Degree of head elevation, this is very important. A degree of 30 degrees may be okay, but increased head elevation to 60 to 80 degrees have the most disastrous effect on the cerebral saturation. So this is important to be considered intraoperatively if there is any event of hypotension or cerebral desaturation. Poor neck position. Poor neck position may hinder the venous circulation, internal jugular venous circulation, and you know that the blood flow from the arterial to the venous side depends on the pressure difference on both sides. So increase in venous pressure can decrease the cerebral blood flow. So how to minimize the neurological complications? First, the lateral to abandon the setting position, the lateral to position. Later on, the studies compared the two positions, and they found that no decrease or no significant decrease in the mean arterial pressure and cerebral saturation in the lateral iliomatosis in comparison to the setting position. So this is one of the solutions. Second, avoid hyperventilation. This is very important. The target level of CO2 is 40 to 42. As we said, the relation between the CO2 level and the cerebral blood flow is a linear relation between 20 to 80 millimeters mercury. But above 50 millimeters mercury, this can abolish the auto-regulation response. Use of regional anesthesia. We can abandon the general anesthesia and its effects, and to use regional anesthesia. A lot of techniques for regional anesthesia, most of which is the interscalene block with sedation. This can have advantages and disadvantages. The advantages is that it abolishes the effect of anesthetics on the cerebral, on the hemodynamics. The sedation can help in increasing the CO2 level within a desired range, but maybe there is failure of technique. The patient may regain sensations intraoperatively. Maybe the position may be not very comfortable for the patient intraoperatively. All these may hinder this. This is very important. Keep the mean arterial pressure near the baseline values or above the lower limit of autoregulation, which is between 50 to 80 millimeters mercury. To keep the blood pressure or the mean arterial pressure at this range, you have to position the transducer of the invasive arterial pressure at the level of the radius to consign process. Application of intermittent compression devices, we said that one factor that decreases the preload, the left ventricular preload, is the pooling of the blood in the lower half of the body. So application of intermittent compression devices can help to decrease this condition, and studies done in this context can make its effect. Lastly, monitoring. I put it at the last slide because we have, as Dr. Salman said, we have a lack of monitoring in our institutes. In this context, we can use the invasive arterial pressure monitoring, especially in high-risk patients and high-risk procedures, to monitor arterial pressure beat by beat to detect the pressure at the cerebral circulation. You have to place the transducer at the level of the radius. Secondly, there is what's known as the cerebral oximetry, or the reflective oximetry. This detects the oxygenation and the arterial, venous, and tissue levels. A drop of the cerebral saturation with 20% below the baseline values is a trigger for cerebral ischemia. Here there is a jugular venous saturation or jugular bulb venous saturation. The saturation in the jugular venous bulb can detect the cerebral ischemia or increase the cerebral blood flow. Increase below 50% is a sign of hypoperfusion, and increase below 30% can be a trigger for cerebral ischemia. Lastly, the wide spectrum analysis. This is one of the monitors for depth of anesthesia. This is analysis of the electrical activity of the brain. A sudden drop of the BIS values below 30 and 39 can be a trigger for alarming you that there may be cerebral ischemia. This is Dr. Mohammed Hassim. Thank you for your listening.